So all ready?
Yes, sir.
Okay, fine. So let's start. Good evening, everybody. Welcome to this evening episode of Pursue. And we have Pursue 12E, the fifth lecture on the respiratory pathology. We are streaming live from Kolkata. And we have a very interesting topic and a very competent person to discuss this topic. The topic of the day is interstitial lung disease. And to talk on that, we have Dr. Sukanta Chakraborty, who is an MBBS from Kolkata, MD from the famous BJ Medical College, Ahmedabad. He is a histo-cytopathologist with experts in invasive diagnostic procedure. He is also the NABL lead assessor and the lab director of Theism diagnostics and a consultant in the famous Kothari Medical Center. He has various publications in national and international journals and is a co-author in the Springer book as well. Before I ask Dr. Chakraborty to take over, let me request all of you to please keep your mic muted, your camera off, and please don't share your screen. With this, let's not waste any more time. Let me ask Dr. Chakraborty, sir, please share your screen and let us start. Just press present now, your entire screen, and press in the center and share. Yeah, I can see your screen. Just share, just choose your PowerPoint, please.
Yeah.
Yeah, make it full screen. Yeah, and press that hide thing. Right, we are ready to go. Please start.
Yes. Good evening, everybody. I am Dr. Sukanta Chakraborty. Thank you all who are joining this live discussion, and thanks to all who will watch it later. And thanks to Dr. Nadim sir for giving me this opportunity. Now, straight away going to today's topic of interstitial lung disease or ILD. Now, what is interstitial lung disease? It is chronic interstitial pulmonary disease. They are a heterogeneous group of disorders characterized predominantly by inflammation and fibrosis of the pulmonary interstitium. Now, how these patients present? They usually present with dyspnea, tachypnea, end inspiratory crackles, and eventually cyanosis. But like other restrictive lung diseases, there is not much wheezing or other sign symptoms. And ultimately, there is right heart failure or cor pulmonale. Now, what is the etiopathogenesis? I will not go in the detail, but yes, there are environmental factors, and most important among them is the association of smoking. ILD is a disease predominantly of smokers. Smoking has a very strong association with interstitial lung disease, and then there are some professional factors like farming, hairdressing, stone polishing. These kind of professions are closely related with interstitial lung disease. Then there are, of course, some genetic factors is associated because all the patients or human beings with these environmental factors do not present with interstitial lung disease. So there is telomere defect of the TERT or TERT gene. This TERT gene mutation is the most important genetic factor related with interstitial lung disease or ILD. Now, it is mostly a disease of the elderly, and usually over 50 years of age, patients present with interstitial lung disease. Now, briefly, what are the pathogenesis or pathological factors which end up in interstitial lung disease? Now, the triggering factors which we have already discussed in the previous slide: environmental factors, genetic predisposition, some drugs are related, and recently gastroesophageal reflux has also been associated with ILD. Now, these factors, what what they do, there is epithelial damage and also endothelial injury. And this epithelial endothelial damage causes destruction of alveolar capillary basement membrane, as well as vascular leak, platelet activation, fibrin clot activation, and these things ultimately causes a epithelial fibroblastic interaction, and this interaction leads to release of profibrotic cytokines, and there is myofibroblast recruitment in the wart zone. There is proliferation and differentiation of myofibroblast and a provisional matrix formation, angiogenesis, and defective re-epithelialization. This re-epithelialization is not with according to the initial normal physiological state. It is defective re-epithelialization, and ultimately aberrant or defective repair and fibrosis occurs, and there is exaggerated extracellular matrix accumulation, lack of matrix degradation, progressive lung remodeling, and ultimately honeycomb changes. These things are in a nutshell the etiopathogenesis of ILD. Now, briefly, what is the important subgroups in ILD, or which is also called diffuse parenchymal lung disease or DPLD? First of all, of known causes like drugs, dust exposure, collagen vascular disease, and next, the most important group of ILD is idiopathic interstitial pneumonias or IIPs. Among IIPs, there is the most prototypical of ILD is idiopathic pulmonary fibrosis or IPF. This is the most famous or most infamous, rather I should say, group of ILDs, IPF or idiopathic pulmonary fibrosis. Then there is other IIPs like discomative interstitial pneumonia, DIP. Later we will see this is strongly associated with smoking, but other subgroups of these IIPs are not that strongly associated with smoking or usually occurs in non-smokers. Acute interstitial pneumonia, AIP, non-specific interstitial pneumonia, NSIP, and bronchiolitis associated ILD, cryptogenic organizing pneumonia, lymphocytic interstitial pneumonia. These are other subtypes of IIP apart from IPF. Next comes granulomatous group like sarcoidosis, hypersensitivity pneumonitis, etc. And there is also other form like eosinophilic pneumonia, etc. So these are in brief subgroups of ILD. Now, before going to individual important subtypes of ILD, we'll quickly discuss few things about indications of lung biopsy in ILD, because what I say, interstitial lung disease is actually a game between the pulmonologist and radiologist, and the surgical pathologist works as a ball boy. When the ball comes out of the field, then only surgical pathologists have a definite role to play. Now, lung biopsy is generally helpful in the evaluation of patients with ILD in the following situations to provide a specific diagnosis. When lung biopsy is indicated, when age is less than 50, there is fever, weight loss, hemoptysis or signs of vasculitis, there is a progressive course of the disease, atypical or rapidly changing HRCT findings are there, and there is unexplained extrapulmonary manifestation or pulmonary vascular disease of unclear origin. In these cases, biopsy is indicated. Now, what are the options of biopsy in ILD? First of all, FNAC is a simple and very less invasive procedure, but in interstitial lung disease, we'll discuss later why it is so. It can only rule out malignancy or diagnose granulomatous disease at the most. Next comes surgical lung biopsy with frozen section, and another option is video assisted transthoracic surgery. There are options of transbronchial lung biopsy, bronchoscopic core biopsy, cryobiopsy, and lastly core biopsy or true cut biopsy. Now, what are the pitfalls of lung biopsy? There is, truly speaking, gross inter-observer variation in some cases, even between experts, because there are many overlapping features of subgroups of subtypes of interstitial lung disease. And radiological features are more definitive in some cases in ILD. Then there can be sampling error because the involvement of the lung is many a times in many subgroups. There is patchy involvement, so sampling from one side can give rise to just normal lung biopsy, and obviously there will be different impression from biopsy from different sites in many cases. And next pitfall is bubble artifact. There is a picture of bubble artifact, and tissue manipulation can lead to this distortion of the lung tissue, and this rounded spaces of different sizes with absence of histiocytes and pneumocytes excludes the true pathological process. This is the image of a bubble artifact. Now, there is a preferred or default format for reporting the histopathological characteristic of bronchoscopic lung cryobiopsy. First of all, there should be a gross description of number of specimens and size with maximum dimension or length, and in microscopic description, for adequacy, we have to report number of fragments, number of terminal bronchioles, number of alveoli, obviously a rough estimate at least, and for feedback to the operator, presence of bronchial cartilage, large airway, large vessel, pleura, etc. Because this sensitizes the clinician to about the probable complications of the biopsy procedures also, and we should report artifacts like alveolar hemorrhage, proteinaceous fluid, implantation of bronchiolar epithelium in alveolated areas, freezing artifact, crash artifact, collapsed alveolar spaces, and finally for diagnosis there should be a morphological description and whenever possible a definitive histopathological diagnosis, and we should report also the diagnostic confidence. Is it definite or it is non-diagnostic or it is somewhere in between like probable or possible. Next is specimen adequacy. I have discussed already in the chart that the specimen of biopsy should be 5 millimeter or more, and it should be a 5 millimeter diameter corresponds to a surface area of about 20 millimeter square. So two coats or two such bits would represent a total surface area of 40 millimeter square, and as we discussed, a larger biopsy will help in the identification of different histological patchy or focal features like honeycombing, fibroblastic focus, patchy fibrosis, which are typical of a usual interstitial pneumonia pattern. And why UIP pattern recognition is most important? Because UIP or usual interstitial pneumonia, as we will see soon in the next slides, it is the histological representation of IPF or idiopathic pulmonary fibrosis. So UIP pattern, which is patchy, should be diagnosed or can be diagnosed by only a larger biopsy. I have already said this. The alveolar adequacy should be represented by number of alveoli, and greater than 100 is generally considered adequate. The presence of sufficient number of terminal bronchioles is also important to diagnose airway-centric pathologies such as bronchiolitis or hypersensitive pneumonitis. The presence of what I have said, the presence of large airways, cartilage, large vessels are to provide important feedback to the bronchoscopist, and presence of pleura represents subpleural sampling, which may be useful in diagnosing idiopathic pulmonary fibrosis. So, coming to a default diagnostic algorithm of ILD. First of all, history, clinical examination, chest X-ray. If it leads to suspicion or diagnosis of DPLD, and in some cases some etiological diagnosis also, like sarcoidosis, like collagen vascular disease, then if no definitive diagnosis, HRCT chest. If in HRCT there is confirmation of DPLD, then identification or suspicion of certain specific diagnosis if there is there, like IPF, like sarcoidosis, like chronic hypersensitivity pneumonitis, it is fine. If not, serological test. Serological test will diagnose collagen vascular disease, sarcoidosis again, and chronic hypersensitivity pneumonitis of a specific allergen or specific cause by diagnosing its specific IgG precipitation. Next in the line is fibro-optic bronchoscopy with examination of ball fluid or bronchoalveolar lavage fluid. We'll have a slide of common ball fluid features of ILD later, but yes, again sarcoidosis comes by increase of lymphocytes and increased CD4-CD8 ratio, and in chronic HP or hypersensitivity pneumonitis there is decrease in CD4-CD8 ratio. And next comes, at the end comes transbronchial lung biopsy, where granulomas can be diagnosed easily, and other diagnosis, if it is achieved, then treatment is given accordingly, and even after lung biopsy the diagnosis is not clear, then there should be a multidisciplinary meeting, and if needed a open lung biopsy to clinch the diagnosis. Of course, it is if it is indicated and necessary for definitive management or prognostication of the patient. So with this we conclude the short discussion of the biopsy options or the goal or indications of biopsy in ILD. Now I will briefly discuss some important subtypes of interstitial lung disease. First of all, as I have said, the prototype is IPF or idiopathic pulmonary fibrosis. It is a chronic scarring lung disease characterized by a progressive and irreversible decline in lung function, manifested as dyspnea, on exertion, and dry cough. So how idiopathic can be stamped? Of course, by exclusion of known causes of ILD, like domestic and occupational environmental exposures, connective tissue diseases, or drug exposure or drug toxicity. When we can exclude these known causes, only then unknown or idiopathic pulmonary fibrosis can be stamped. And the presence of a typical radiological pattern of UIP or usual interstitial pneumonia on HRCT is needed to diagnose IPF. And in the right clinical setting, it is possible to make the diagnosis of IPF by HRCT alone, obviating the need for surgical lung biopsy, because lung biopsy is not at all easy and not at all easy to diagnose from a small tissue bit, and it is actually impossible to diagnose alone by histomorphology or histopathology of a small lung bit the specific subtype of ILD without inputs from the clinician, without inputs from the bronchoscopy, from HRCT, etc. So IPF or UIP, its histological counterpart, usual interstitial pneumonia, and it is also called cryptogenic fibrosing alveolitis. It is the preferred term in European literature, cryptogenic fibrosing alveolitis, and histopathology shows diffuse alveolar damage pattern, diffuse damage of the alveoli, but the common form is mixed exudative and organizing phase. Exudation phase and this organizing phase together in different areas of the lung biopsy is characteristic of UIP. And what is shown in this picture, interstitial edema and hemorrhage is there. As you can see, interstitial edema and hemorrhage is there in A areas, and in B areas there is diffuse alveolar thickening and formation of hyaline membrane, and type 2 pneumocyte hyperplasia is there in C areas. All these things are mixed in at the same time in different parts of the biopsy. So, what is UIP in a nutshell? Little bit of inflammation. Inflammation is less or spots in IPF. There is lower lobe predominance. There is patchy subpleural and paraseptal distribution. There is absence of granuloma or dust deposit or eosinophil. Presence of these things will indicate to a different diagnosis, and to differentiate with UIP pattern of connective tissue diseases. In rheumatoid arthritis, there will be more of inflammation and pleural fibrosis. In scleroderma, there will be lymphoid nodules commonly, and in hypersensitivity pneumonitis, there will be centrilobular fibrosis. And of course, adverse drug reaction can present a UIP-like picture, so drug history is very, very important. Next in entity is non-specific interstitial pneumonia, or in short form it is called NSIP. Again, to rule out drug-induced collagen vascular disease or hypersensitivity first. Then the histopathology of NSIP will come as characterized by a temporally homogeneous inflammatory and fibrosing interstitial process. Fibroblastic foci and peripheral accentuation are typically absent, which helps to differentiate it from usual interstitial pneumonia. So, first, inflammation is more, and NSIP is also characterized by diffuse alveolar wall thickening by uniform fibrosis, but with the preservation of the alveolar architecture. So, in UIP, inflammation less, but alveolar architecture is damaged. In NSIP, inflammation is more and there is preservation of alveolar architecture, and it is prognostically better than IPF or UIP. So, three separate groups within NSIP have been described. Group 1 is mainly of interstitial inflammation, and group 2 is a in-between thing, inflammation and fibrosis together, and group 3 is mainly fibrosis. So this is a group 2 picture of mixture of inflammation and fibrosis. Next in line is lymphocytic interstitial pneumonia, or LIP. It is a syndrome of fever, cough and dyspnea with bibasilar pulmonary infiltrates consisting of dense interstitial accumulations of lymphocytes and plasma cells. So, LIP, there is also association of definitive systemic diseases like autoimmune and lymphoproliferative disorders, including RA, Hashimoto's, myasthenia gravis, pernicious anemia, autoerythrocyte sensitization syndrome, chronic active hepatitis, common variable immunodeficiency, Sjogren's, allogenic bone marrow transplantation, lupus, and lymphoma. And we have to diagnose LIP, we have to, when the lymphoid infiltrate is very, very dense, I'll come to the histological picture, then we have to exclude clonality of the lymphoid aggregates to exclude lymphoma. And pseudolymphoma is, as we know, is a mimicker of lymphoma, and it represents a localized mass-like variant of lymphocytic interstitial pneumonia. So, there is, to summarize, diffuse interstitial infiltration of polymorphous lymphocytes. If it is monomorphous or monoclonal, then it will be lymphoma. Polymorphous lymphocytes and plasma cells, lymphoid follicles with germinal centers, histiocytes and macrophages are often present. Bronchovascular bundles and interlobular septa are usually involved, and alveolar structure is often inflated and disrupted. And typically, CD8 plus or CD4 plus T cells or B cells predominate, with an admixture of other lymphocytes. And IHC or molecular is sometimes needed, as I said, to confirm polyclonality, with this to exclude lymphoma. So this is histological picture of lymphocytic interstitial pneumonia. We can see dense collection of lymphocytes and plasma cells, and in this picture there is some localized aggregates or dense aggregates of lymphocytes. So this is in short LIP. Now comes some other entities which also gives rise to ILD like picture, like pulmonary Langerhans cell histiocytosis, or another name is eosinophilic granuloma, and now smoking associated entities are coming. This is strongly associated with smoking, and there is interstitial involvement, so it comes in the discussion of ILD. And as we know, Langerhans cells are these cells are elongated. These cells have, we can I don't know how clear it is from the picture, but the Langerhans cells are elongated grooved nuclei with glassy pink cytoplasm, elongated grooved nuclei with glassy pink cytoplasm and syncytial appearance of staying together. And we know they are S100 and CD1A positive, and we should remember that this is a subgroup of ILD which occurs in younger patients or young adults, this LCH. Now quickly some other subgroups of ILD. Aspiration pneumonia can also give rise a picture of interstitial lung disease. There is aspiration pneumonia is centered around small bronchioles. Small bronchiocentric inflammation and fibrin deposition is there in aspiration pneumonia. And in bronchiectasis, there is dilatation of the bronchioles, and with that there is airway inflammation along with fibrosis. These are a very short discussion on some other subtypes of ILD. Next comes allergic bronchopulmonary fungal diseases. These are also included in interstitial lung disease, and there is mucoid impaction of the bronchi. Mucoid impaction of the bronchi is there in allergic bronchopulmonary fungal disease, and there is bronchocentric granulomatosis. Bronchocentric granulomatosis will be there in fungal bronchopulmonary in ILDs. So, which is left? Small airway disease like bronchiolitis. There is epithelial sloughing and fibropurulent debris. There is epithelial sloughing and fibropurulent debris will be there in bronchiolitis. And the histological subtypes may be granulomatous, follicular, or diffuse panbronchiolitis, where there will be foamy histiocytes in the interstitium. Now, we have more or less covered the IIPs, including its most important subgroup of IPF, which histologically is histological counterpart of IPF, as I have told repeatedly, is UIP or usual interstitial pneumonia. Now granulomatous ILDs will come, and among them most important is sarcoidosis. As we all know, sarcoidosis is a multi-system disease. It is of unknown etiology, and characteristic of sarcoidosis is non-causating granulomas, we all know, and there is increased CD4 plus cells in sarcoidosis, and there is of course lung, other viscera, skin and eye involvement. And histologically, apart from non-causating granulomas, another important feature of sarcoidosis will be interstitial fibrosis, and there is Schumann bodies and asteroid bodies characteristically. This is a histological picture of sarcoidosis. As we can see, beautiful confluent, they are merging with one another, confluent non-causating granulomas, which are called naked granulomas because there is very less lymphocytic cuffing around the collection of epithelioid histiocytes. And morphologically, epithelioid cells in sarcoidosis are a bit plumper, a bit more plump than tubercular epithelioid histiocytes, and these are confluent granulomas. There is a giant cell in this picture, Langerhans type of giant cells, and these are calcific concretions which are called Schumann bodies, which are characteristic of sarcoidosis, and there is typical stellate-shaped inclusions or star-shaped inclusions called asteroid bodies. Next, hypersensitivity pneumonitis, which I have named again and again in the discussion of classification or in the discussion of IIPs, where always as some specific connective tissue diseases, some some allergens, some drug reactions should be excluded to diagnose the idiopathic conditions or non-specific conditions. Now, what is there in hypersensitivity pneumonitis? First, there can be acute forms, there can be subacute forms, and there can be chronic forms. And subacute forms are mostly biopsied. Acute forms are showing airway-centered inflammation with little fibrosis and neutrophilic infiltration with or without capillaritis is acute hypersensitivity pneumonitis. And intra-alveolar fibrin deposition may also be there. These things are common in acute HP. And in subacute HP, there will be a mixture of acute and chronic form, of course, and airway-centered inflammation will again be there, but with fibrosis. And lymphocytic infiltration with granulomas or giant cell can be there. And in chronic form, predominantly airway-centered inflammation with diffuse fibrotic change. Lymphocytic infiltration will be there with granulomas or giant cells. Granulomas or giant cell can come. And this chronic HP, as we discussed during discussion of the IIPs, they can often overlap with NSIP, UIP, organizing pneumonia, and airway-centered interstitial fibrosis. And bridging fibrosis can be there in chronic HP. And what is bridging fibrosis? Fibrotic band connecting bronchioles with each other and with lobular septa. And peribronchial metaplasia can be a diagnostic clue to differentiate between HP and IPF in cases of fibrosis. So these are different subtypes of hypersensitivity pneumonitis histologically: acute, subacute, and chronic. So to summarize again, what is hypersensitivity pneumonitis? It is caused by intense and prolonged exposure, continuous, intense, prolonged exposure to inhaled organic antigens or hypersensitivity pneumonitis. And they are immunologically mediated. There is increased level of pro-inflammatory cytokines in HP, and common culprits of HP are actinomycetes, saprophytic fungal spores, animal and bird proteins, methotrexate as a drug, chemicals like farmers, painters, cheese workers, bird fanciers, rodent workers, air conditioner mechanics, they are more prone to HPs because these chemicals can give rise to hypersensitivity reaction in the lung. So, interstitial pneumonitis, non-causating granulomas, interstitial fibrosis, and in the late stages, obliterative bronchiolitis. This characterizes HPs. This is a histological picture of low power view of HP, and in a bit higher power we can see the giant cell and some histiocytic reactions. Next comes eosinophilic pneumonia. Acute form of eosinophilic pneumonia has diffuse alveolar damage, and alveolar and interstitial infiltration by eosinophils, plasma cells and histiocytes are characteristic. And there may be Charcot-Leyden crystals in eosinophilic pneumonia, and variable angiitis, granulomatosis, fibrosis, mucus plugging and bronchiolitis with necrosis can be there. And in chronic form, there is usually some secondary causes like fungus, parasite, rheumatoid arthritis, radiation, smoking, Hodgkin's disease, inflammatory bowel disease, bronchogenic carcinoma. These are common secondary causes of chronic eosinophilic pneumonia. And this is a picture of acute eosinophilic pneumonia. The lung parenchyma is studded with eosinophils. Next, some categories are left like acute interstitial pneumonia, discombative interstitial pneumonia, which are common in smokers, and cryptogenic organizing pneumonia. We will discuss this in my day after tomorrow. I have a presentation on alveolar filling lesions, as these two topics of ILD and alveolar filling lesions are overlapping, and these things AIP, DIP, cryptogenic organizing pneumonia, they are considered in alveolar filling lesions also. I will discuss these entities in my next talk. So, what is left? There is a big group of ILDs are left now only. They are pneumoconiosis. I will discuss very shortly about the common pneumoconiosis, which are pneumoconiosis is to say briefly, it is occupational hazard of giving occupational diseases giving rise to interstitial lung disease. Pneumoconiosis may be classified as either fibrotic or non-fibrotic according to the presence or absence of fibrosis. So, what are fibrotic pneumoconiosis? Silicosis, coal-worker pneumoconiosis, asbestosis, berylliosis, and talcosis are examples of fibrotic pneumoconiosis. And on the other hand, siderosis, stenosis, and barytosis are non-fibrotic forms of pneumoconiosis that results from inhalation of iron oxide, tin oxide, and barium sulfate particles respectively. So, fibrotic group and non-fibrotic group. And fibrotic group is more common as well as more important. The most important form of fibrotic pneumoconiosis is coal-worker pneumoconiosis. And in its most benign or most indolent form is called anthracosis, which in this anthracosis we can see only carbon-laden macrophages accumulation in the lung parenchyma. And without being exposed to coal work or without being a coal worker, anthracosis can also be there in urban population living in polluted areas as well as in smokers. As we can see in our patient population, any lung biopsy in any non-neoplastic lung biopsy, shows carbon-laden macrophages accumulation to some extent. So this is anthracosis group, which can be of coal workers and can be of smokers, can be of urban habitats also. Next stage is simple coal worker pneumoconiosis, where coal macules and coal nodules are formed with upper lobe predominance, or upper part of lower lobe can also be involved. And another subgroup is complicated CWPs, where progressive massive fibrosis will be there. In most of the subtypes of pneumoconiosis, the ultimate or the grave end is progressive massive fibrosis. Next is silicosis. Initially, silicosis gives rise to tiny nodules in lung and also in mediastinal lymph nodes. Very tiny nodules. Next, hard collagenous scars are formed. And in radiology, silicosis gives rise to a typical pattern of fine calcification, which are called eggshell calcification. And ultimately, as I have already said, there is progressive massive fibrosis. And this image of silicosis is showing a late stage of collagenous silicotic nodules. Collagenous silicotic nodules are there. Next is asbestosis. Asbestosis is a long-term inflammation and scarring of the lungs due to asbestos fibers. And symptoms may include shortness of breath, cough, wheezing, and chest tightness. And not like other type of pneumoconiosis, asbestosis is more commonly related with lung cancer, mesothelioma, and pulmonary heart disease. And what is there in asbestosis? Diffuse pulmonary interstitial fibrosis, and asbestos bodies can be seen in biopsy. In lung biopsy, there is golden brown fusiform or beaded rod-shaped structures which are called asbestos bodies, and there can be pleural plaques also. Next, which is left, therapy-induced interstitial lung diseases. First of all, drug-induced cases, and common drugs giving rise to ILD are cytotoxic drugs like bleomycin. Amiodarone is a known culprit for ILD, and intravenous drug abuse can also be a cause of interstitial lung disease. And therapy induced, apart from drug, there can be radiation induced ILD, and in acute form, acute radiation induced ILD is nothing but a type of hypersensitivity pneumonitis. And in chronic form, there is pulmonary fibrosis and diffuse alveolar damage. Now, collagen vascular disease also gives rise to interstitial lung diseases. And what are the common patterns according to the common connective tissue diseases? In systemic sclerosis, there is commonly NSIP, and in the right hand section there is radiological features mentioned: ground glass opacification, basilar prominence, etc. And UIP feature can also be there, where peripheral and bibasilar reticulonodular opacities can be there, and honeycombing also. So systemic sclerosis, NSIP, UIP both. RA also UIP is more common, but NSIP can be there. In polymyositis, dermatomyositis group, NSIP, UIP, cryptogenic organizing pneumonia, all can occur. Diffuse alveolar damage also. In Sjogren, NSIP or LIP, lymphocytic. In SLE, acute interstitial pneumonia, AIP can occur. And in MCTD, mixed connective tissue disease, there is NSAIP. Next, before conclusion, the role of ball fluid examination in interstitial lung disease. Ball fluid cannot contribute in all the subtypes. But if there is eosinophil more than 25% eosinophilic, lymphocyte if is increased, a broad spectrum of disease from sarcoidosis to lymphoproliferative disorders. If neutrophils are more acute, diffuse alveolar damage, pulmonary infection, etc. If bloody fluid is there, pulmonary hemorrhage, diffuse alveolar hemorrhage, which these entities we will discuss in the next talk, and high hemocytidine score of course in hemorrhagic conditions, and CD1A positive cells more than 4%, Langerhans cell histocytosis pulmonary, milky fluid, pulmonary alveolar proteinosis, and of course if malignant cell is there, pulmonary malignancy. One is like blood parameters, not at all specific, but microcytic anemia occurs in occult pulmonary hemorrhage, and eosinophilia in eosinophilic, leukocytosis in infections and malignancies, thrombocytopenia in sarcoidosis, hypercalcemia again in sarcoidosis, and creatinine increased in connective tissue diseases and sarcoidosis, liver function derailed in sarcoidosis or amyloidosis, as well as CTDs, urine abnormal sediment with RBC cast in vasculitis, muscle enzyme increased in polymyositis, dermatomyositis group, increased AC in sarcoidosis, and these are common blood parameters, non-specific, but there are some suggestions. Now, there are some novel biomarkers also in DPLD. I will not, molecular markers will probably be discussed in some another talk by another speaker. So, I will just mention a few names: CCL18, MMP7, CXCL12, MMP12. These are effective biomarkers for predicting severity and progression of lung involvement in systemic sclerosis or scleroderma. And serum, it is not KL6, it is IL-6. High IL-6 will indicate interstitial lung diseases, and CA15-3 serum level is strongly elevated in patients with ILD also. So, what are to summarize? As this is not take home because most of us are sitting in home, so it is keep home message. DPLD is not primarily surgical pathology domain, as I have said in the beginning. We can play a supportive role only. And areas like granulomatous lesions, collagen vascular disease, eosinophilic pneumonia, etc. need significant lab diagnostic support. And on the other hand, IPF and other IIPs are mainly clinico-radiological. And biopsy is done only in cases of diagnostic confusion. And clinical details and radiological features are absolutely necessary, as so is generous biopsy. And histomorphologically alone is not diagnostic at all. And many IIPs have overlapping histological features. So, what a surgical pathologist can do, he or she can play an important member of multidisciplinary team only. With this, I conclude my discussion on interstitial lung disease. Thank you all very much.
Thank you so much. Wonderful presentation, Dr. Sukanta. Excellently put up. The entities are very many, and the reason why we have chosen this topic in the entire spectrum of our respiratory diseases and to include them in this entire thing is that with the increasing frequency of lung biopsies, and the more we are getting used to doing lung biopsies, we are sooner or later going to be seeing more of these non-neoplastic lung biopsies as well.
Yeah.
So it is very important for us in our setting to start getting used to, because lung biopsies we always think it's neoplastic.
Yes.
But things are going to change over a period of time as the radiologists, the interventional radiologists, the surgeons, the physicians are getting more and more comfortable with lung biopsies, as they are becoming more and more comfortable getting used to handling the various minor complications of lung biopsies. They will become more and more aggressive in trying to reach out to the lung in all sorts of lesions, not only neoplastic but also inflammatory, interstitial, bronchoalveolar. So it's become very important for us to address this. And let me congratulate you. You have done a wonderful job in trying to put the entire thing in perspective. So nicely you have taught us like a teacher, one by one, trying to repeat it again and again so that we all understand the subject very well, right from the beginning till the end. And we will surely see you on Friday with the alveolar filling lesions, which are, because both of them are, they complement each other.
Yeah.
And they're not far apart. So that will complete the entire gamut of these bronchoalveolar lesions, and then we will be able to understand things well. And then Saturday there's another talk by another person who's a specialist respiratory pathologist, internationally famed, who will then tell us exactly what is happening on the international arena on these areas, so that we become completely wiser and we know the exact substance very well. Thank you, Dr. Sukanta. There are no questions, as I can see, neither on the YouTube nor on the Google Meet. Thank you so much for this wonderful presentation, and thank you for taking out time from such a busy schedule. You are such a busy pathologist in Calcutta. To take out time for teaching is a wonderful job. God bless you. Thank you so much. Take care. See you on Friday. Good night. Bye-bye.
Thank you, sir. Good night.
Bye-bye. Thank you. Bye.